Sure.
Good morning, everyone. Today, Desai will be presenting the case and it will be moderated by Professor Kalayrasan, Professor R.A. Sastry, and Professor Prabhu. I think Professor R.A. Sastry and Prabhu will be joining us shortly. Now, Kalay, you can take over from here.
Yeah, sure, sir. Thank you, sir. Yes, Desai, you can start your presentation.
Good morning, sir. I'll start sharing my screen.
Yeah.
Is it visible?
Yeah, please go ahead.
Good morning. I'm presenting a case of 46-year-old lady, a homemaker resident of Telangana, who presented with chief complaints of pain in the abdomen since the past 1 month, yellowish discoloration of eyes and urine since the past 2 weeks. Patient was apparently all right 1 month back when she started developing sudden onset, severe, intermittent pain in the epigastric region, radiating to the back, associated with multiple episodes of small quantities of bilious vomiting. Pain was aggravated after oral intake and relieved by injectable analgesics and not relieved on bending forward. Patient also complains of progressively increasing yellowish discoloration of eyes since the last 15 days. There is no history of waxing or waning of discoloration. There is history of passing high-colored urine since 2 weeks. There is history of passing acolic stools since the past 15 days. History of generalized itching is present since past 2 days, leading to sleep disturbance. There is also history of unintentional loss of weight, 7 kgs in the past 1 month with loss of appetite present. There is no history of fever, no history of silver-colored stools, no history of any drug abuse or alternative medication intake. There is no history of hematemesis, melena, postural dizziness, syncope, fatigue, shortness of breath, or any need for blood transfusion. There is no history of respiratory discomfort, hemoptysis, bone pain, or backache. There is no history of recent onset of diabetes. 2 histories which were not mentioned, I would like to ask, is the history of association of food intake for vomiting and any food content was present in vomiters or not, since the patient is having episodes of bilious vomiting, multiple episodes of bilious vomiting, and any history of hospitalization or previous treatment history is available since she required injectable analgesics for her pain relief. She is a known hypertensive since past 10 years, history of lower segment cesarean section 20 years back, no past history of recurrent pain in upper abdominal episodes or a history of jaundice in the past. Family history is not significant. The sleep is disturbed due to itching. Appetite is reduced. Bowel and bladder habits are normal and regular. She's a mixed diet consumer and no addictions. To summarize, it's a case of 46-year-old lady, non-diabetic, presented with sudden onset, intermittent severe upper abdominal pain, radiating to back with multiple episodes of small quantities of bilious vomiting since last 1 month. Pain was aggravated after oral intake and relieved by injectable medications without any postural variation. She also had progressively increasing jaundice with acolic stools and generalized itching with sleep disturbance for the last 15 days, associated with significant weight loss of 7 kgs, unintentional weight loss of 7 kgs in the past 1 month with loss of appetite. There is no history of previous episodes of recurring abdominal pain or recent onset of diabetes.
Okay, so these are your differential diagnosis, what you have written, right?
Yes, sir.
So that, and also it's in the order of priority.
Preference, sir. Yes,
Yeah.
sir.
So you can tell the points in favor of your first diagnosis and anything against.
Yes, sir. I've kept choledocholitis with pancreatitis as my first diagnosis because she's a young patient, firstly. Second, the pain described is a severe sudden onset pain. Secondly, sudden onset pain and associated with small quantities of bilious vomiting. I would have liked to ask in the history whether it is any food content or not to differentiate whether it is because of pancreatitis or gastric outlet obstruction, but the history was not provided. The points against choledocholitis is loss of appetite and...
just come again, I think you want to know about the food intake. So what is the difference in pancreatitis versus gastric outlet obstruction?
Sir, in case of gastric outlet obstruction, we see the duration of the vomiting postprandial relation to the food intake. after food intake, after how much duration the patient is vomiting, whether there is any residuals of undigested previously undigested food particles present or not, and it is usually not of a bilious nature. While the vomiting in pancreatitis may be due to reflux and secretion of enzymes post-oral intake, which is causing small episodes of bilious vomiting in the patient. The points against in case of choledocholithiasis is she is having
you
loss
can
of
see basically in pancreatitis, you can have vomiting to the edema also, right?
Yes, sir.
Most often.
Yes,
And it may not be bilious because
It may-
that also can be obstruction can be in the first part. Right?
yes, sir.
You need to keep that in mind. So because you can't give so much importance to that because you said that point twice. So
Yes,
it
sir.
may not be really that different between the two etiology. Okay, the point against this?
She's having significant unintentional loss of weight and loss of appetite within a 1 month duration. That is a point against it, sir.
Anything?
And she has a progressively increasing jaundice with ecolic stools suggestive of complete obstruction of the biliary tract.
Then?
And she's also having pruritus with sleep disturbance, which is not so common in case of choledocholithiasis.
No, anything which is typical of benign obstruction.
Sir, there is no prior history of gallstone disease given any recurrent episode.
Was there any fever? Fever was there?
No fever, sir. There was no fever.
So that's also important, right?
Yes, sir. There is no fever.
Okay. Your second is pancreatic head mass. Malignant pancreatic head mass.
With obstructive jaundice and a possibility of gastric outlet obstructions.
Okay.
Because she is having loss of appetite and significant unintentional weight loss, progressively increasing jaundice, and
So
because
why
of
you kept a duodenal mass above carcinoma gallbladder?
Sir, first, because she's not a resident of the typical North Indian belt in which the prevalence of gallbladder cancer is more. Secondly, a duodenal mass has a higher chance of presenting with gastric outlet obstruction, and if it is rising from D2 and obstructive jaundice simultaneously, then carcinoma gallbladder next. And the onset of pain and the duration of symptoms does not correlate with a gallbladder carcinoma presenting this early, sir.
Fine. So we'll proceed. Maybe any comments from others before we proceed to examination.
Yeah, I think you can go ahead because I joined in.
Okay. Fine. So
Good morning.
yeah. So proceed to the examination.
Okay, sir. She was conscious, cooperative, oriented to time, place, and person for general examination. BMI, body mass index is 29 kilogram per meter square. She is moderately built and well nourished. ECOG status is 1 with a breath holding time of 36 seconds. Icterus is present. There is no pallor, cyanosis, clubbing, lymphadenopathy, or edema present. The pulse rate is 90 per minute. Blood pressure is 128 by 86 millimeters of mercury. Respiratory rate is 16 per minute. Efebrile. The SpO2 is 98% on 2 min. There are no enlarged left supraclavicular nodes present. There are no signs of malnourishment present. On per abdominal examination, the abdomen is flat with umbilicus central in position inverted. All quadrants move correspondingly with respiration. There is no visible peristalsis, sinuses, or engorged veins present. Healthy scar of previous lower segment fissure infection is seen. Scratch marks are present. Hernial orifices and external genitalia appear normal. Bilateral venal angles appear normal. On palpation, abdomen is soft and non-tender. The liver and spleen are not palpable. There is a soft, globular, non-tender, smooth swelling palpable in the right hypochondriac region, moving with respiration. Hernial orifices, external genitalia, there is no palpable impulse. Point missing in the history, I would like to add because of possibility of gastric outlet obstruction, there is presence or absence of sufficient splash in the examination. On percussion, liver dullness is palpable on the fifth upper border, is palpable on the fifth intercostal space in the right midclavicular line with a liver span of 13 centimeters. The flanks are tympanic, no signs of free fluid. Auscultation, normal bowel sounds are heard. On digital rectal examination, the anal tone is normal, no palpable pelvic deposits, and the gland is stained with grayish stools. The respiratory system is normal. The examination is normal with bilateral air entry is equal, no gravitation added sounds. Cardiovascular system examination, heart sounds are normal with no murmurs. The central nervous system examination, higher mental functions are normal and no focal neurological deficits were found. To summarize, the case is a 46-year-old lady, non-diabetic, presented with sudden onset of intermittent severe upper abdominal pain, radiating to back with multiple episodes of small quantities of bilious vomiting since the last 1 month. The pain was aggravated after oral intake and relieved by injectable medications without any postural variation. She had also progressively increasing jaundice with acolic stools and generalized itching with sleep disturbance for the last 15 days, which was associated with unintentional significant weight loss of 7 kgs in the past 1 month with loss of appetite. There is no history of previous episodes of recurring abdominal pain or recent onset of diabetes. The general examination shows jaundice and scratch marks over the abdomen without any signs of anemia or palpable left supraclavicular lymph node. Abdominal examination shows a palpable non-tender gallbladder without any signs of free fluid, and digital rectal examination shows presence of clay color stools without any presence of pelvic deposits.
So you have basically ruled out the choledocholithiasis.
Yes, sir. Because of the gallbladder was palpable, sir, and there was no signs of fever.
Now you have given a differential diagnosis as these three. So
Yes,
can you
sir.
justify why you are giving this in a particular order?
Yes, sir. Sir, I have kept my first differential as a malignant pancreatic head mass. The reason being that the patient has progressively increasing jaundice and there is no waxing or waning present. There is no associated history of melena or signs of melena present. There is complete obstruction of the biliary tract, which is shown by acolic stools, and the patient has unintentional significant weight loss with loss of appetite.
Why you remove the pancreatitis part, which was there previously now? Can malignant tumor?
It can they can have, sir, but usually if we are suspecting gastric outlet obstruction, the history of succussion splash was not given, which I assume that there was no gastric outlet obstruction present, or I would like to see the history to put the differential of pancreatitis or a possible gastric outlet obstruction.
Gastric outlet obstruction because this patient has bilious vomiting. So how can that be gastric outlet with bilious vomiting?
The obstruction of, sorry, I would rephrase, sir. Obstruction of the duodenum after the insertion of the major papilla, sir.
Okay. So, but your third differential diagnosis is carcinoma gallbladder. Why is it so? Because on an examination as well as history, you don't have a particular finding of CAGP.
So it is not particular. That's why I kept it as a late in my probable list of diagnosis. But carcinoma gallbladder neck can be present with similar complaints of abdominal pain with jaundice and possible features of gastric outlet obstruction. Also, with the history, it is no, I cannot accurately rule out carcinoma gallbladder neck in the patient, sir, because the gallbladder may still be palpable in case of gallbladder neck because of mucosal formation.
So another thing what you have missed is patient had typical pain, which also may point out towards the malignancy of the head of the pancreas. So patient had pain in epigastric which was radiating to back, is it not?
Yes, sir.
So which malignant tumors will have associated pancreatitis?
Sir, malignant transformation associated with a cystic neoplasm like IPMN may present with the history of pancreatitis. Periampullary tumors sometimes may have associated history of pancreatitis present, sir. Head mass patients do not usually present with a simultaneous history of pancreatitis, usually, sir.
I mean, not head mass, you mean pancreatic adenocarcinoma.
Adenocarcinomas.
So let's move ahead. Yatsi sir, you want to make any comments or can we move ahead? Fine. Okay, you can proceed. So how you want to evaluate this patient further?
Sir, I would like to review the previous investigations if they are available, sir.
No, you can ask, so it will be provided.
I would like to proceed with routine blood investigation, sir, including a complete blood count of the patient, renal function test, liver function tests, INR of the patient, and serum CA19.9 levels of the patient, sir.
So you want to do CA99 right away, or you want to wait for some other investigation to come and then ask for it?
Sir, since my probable diagnosis is a malignant tumor, sir, I would simultaneously proceed with the blood investigations with CA19 with the other investigations. So the hemoglobin is normal, which is corroborated with the history there is no history of melena or anemia present, sir. The blood counts are normal, suggested there is no sepsis, which is there also no fever. The platelets are normal. I'd like to see the liver function test next. So the picture is suggestive of obstructive jaundice with a total bilirubin of 9 and a direct component of 4.9 with subclinical cholangitis present due to raised liver enzymes and ALP. The INR is within normal range, 0.92, sir. That is, there is no coagulopathy present. I'd like to see the renal function test. The blood urea and creatinine are within normal levels, it's at normal hydration, and the renal function is normal. The electrolytes are also within normal limits, sir. I would see the CA19-9 levels if they are available. They are within normal limits, sir.
So now what will it say? You wanted to use this as a malignancy as your diagnosis?
Sir, it is not for diagnosis, sir, but as a prognostication marker, the CA19.9 levels may still be normal even if the patient has malignant tumor, because it is basically Cial-Lewis antigen, and the patients who don't have these antigens present, they still may have normal CA19.9 levels despite of having a malignant tumor. So it is more of a prognostication and as a baseline marker before proceeding further.
I would still wait for the radiologic investigation before getting a marker like this.
Okay, sir. I would proceed with the ultrasound abdomen and a chest X-ray of the patient, sir. Sir, the report is suggestive that there is bilobar IHBRD present with a dilated CBD and suggestive of an infracystic block. The pancreas and the distal CBD are obscured, so exact origin is difficult to comment from this. There are no signs of free fluid, and the liver appears normal with no lesions visible on the ultrasound abdomen. And there is an umbilical hernia with an omental fat also noted simultaneously.
What is your likely diagnosis now based on this ultrasound abdomen?
Sir, I would. It is probably it is a. I've from my list of differentials, sir. I would rule out carcinoma gallbladder neck definitely from this. I would still put a periampullary or a pancreatic head malignancy because ultrasound it may not clearly be able to differentiate with accuracy in both diagnosis, sir.
No. See, what they mention is visualize head and body appears normal. Only tail is obscure.
Yes, sir.
So, I mean, I'm not telling you to rule out. The question was, what is your most likely diagnosis?
It may be a distal CBD or periampullary malignancy, sir.
Most probably it's a distal CBD cholangiocarcinoma. Okay?
Cholangiocarcinoma. Yes.
Most likely. So you have to basically, because your order in the clinical examination was pancreatic head cancer. Obviously, you don't rule it out. But
Yes,
the
sir.
order will change, at least based on looking at these findings.
Okay, sir.
So it's a periampullary, ampullary, lower end, or the. Okay, fine. So what do you do next?
Sir, first, since the patient is having a picture of subclinical cholangitis with raised liver enzyme levels, I would advise admission to the patient with starting of IV antibiotics to the patient. And I would rehydrate the patient with IV fluids and increase fluid intake. And I would proceed with the next radiology investigation as a CT pancreatic protocol, sir. Contrast and CT abdomen with CT pancreatic protocol with IV and negative oral contrast.
So I'm just asking you because this, based on this ultrasound, it looks more like a periampullary tumor. So why don't we do a side wing endoscopy for diagnosis?
Sir, it's an invasive procedure, sir. And even if we see a mass and we take a biopsy, the yield may not be 100% accurate, and it may not affect the management further. A CT will help to definitely locate the lesion and stage the tumor if it is present to guide our further management than before doing an invasive procedure.
No, some of the statements may not be accurate. See, you told which is the most diagnostic among these two. If you see a lesion on side wing endoscopy, and if you see a lesion on CT, which has the more highest diagnostic yield?
I agree, sir, that and a side wing endoscopy would be more diagnostic, sir, but it would not give more complete information to guide our further management as compared to a CT, sir. And it being invasive, I would proceed with a CT first.
So that means you're not going to do a side wing endoscopy in this patient?
Not necessarily, sir. I would decide that after viewing the CT scan and how my patient progresses.
What percentage of patients will pick up a small lesion in the lower end of the CBD or a small periampullary? That is what I think Kalai wants to ask. So are you so sure that you will be able to pick up a small lesions?
No, sir, but I would be able to see a ductal cutoff, which would be suggestive of a lesion, sir. And that being a non-invasive test, I would definitely do a CT first and followed by endoscopy if it is required, sir.
See, the other explanation you could give for this case, for this question is, because this patient is having a subclinical cholangitis, right?
Yes, sir.
So you might require a stenting in this patient.
We might, sir, but I would first give a trial of antibiotics, sir. It is only medically refractory cholangitis which is indicated for stenting. So I would not put that indication for endoscopies.
Okay. So in case if you have any possibility of a stenting, okay, you would generally do it after doing a cross-section imaging.
Yes, sir.
Okay. So that is something which, in case when you are asked about this type of a question, so you can think whether this patient might require a stenting. Okay. In case if stenting is required, so it's always better to combine that as a single investigation. You can do a side wing and then do a stenting. And it's
Okay.
always preferable to do it after a cross-section imaging rather than doing it before a cross-section, because obviously that is going to might interfere with the interpretation of the imaging finding. Okay. So whenever that question asks, you can just plan how you are going to sequence your investigations. So you want to do a CT, right? So let's see that.
Yes, sir.
So what CT?
So I would do a contrast enhanced CT of the abdomen with a pancreatic protocol, sir.
Only abdomen?
Of the abdomen and pelvis with a pancreatic protocols.
So I think you should also combine a CT chest also in the same sitting, because that will give you a good evaluation of the pulmonary fertilizing metastasis rather than going back and then doing it later on. So it should be CT chest, CT abdomen, pancreatic protocol and pelvis.
Okay, sir.
So just quickly tell about the specific differences in the pancreatic protocol.
Sir,
Pancreatic. You are doing that.
Yes, sir. So pancreatic protocol is a multidimensional CT done with a dual phase with an IV and a negative oral contrast done with a 1 to 3 mm slice thickness with a contrast injected at a rate of 3 ml per second. And we take the CT in different phases to see the arterial and pancreatic or a venous phase. So taking a cut at 30 to 40 seconds will give us the late arterial or the pancreatic parenchymal phase. And at 60 to 70 seconds, the CT is taken after injecting of contrast to see the portal venous phase. In the not usually a part of pancreatic protocol, but added is an early arterial phase, which is taken at around 15 seconds, which shows early enhancement of certain tumors, which may point towards the neuroendocrine origins.
Okay. So when you are suspecting any neuroendocrine tumors, right?
Yes. Yes.
Okay, good. So let's take.
Yeah, can you describe?
Yes, sir. This is an arterial phase of the CT pancreatic protocol, sir. It shows that the liver has normal parenchymal attenuation with bilobar IHBRD and dilatation of the common bile duct. With the pancreatic parenchyma in the body and tail is normal with a dilated major pancreatic duct, and with cutoff in the head uncinate region with a head mass present, which shows heterogeneous enhancement on the arterial phase. There are I could not appreciate. Could not appreciate. Yes, sir.
Which is it head mass? Where is the you do have a pointer with you, no? Can you just point out the diagonal for saying it is a head mass or it is an uncinate mass? What is it?
So the duodenum is here. It is mostly a head uncinate mass. It is going more towards the uncinate, but is involving the head as well, sir. There is no regional lymphadenopathy I can appreciate on the imaging. There are no signs. I've had to view the pelvis. There is no signs of free fluid or any liver lesions present. There is no gastric outlet obstruction present in the imaging. And to further see the vascular involvement, I like to see the portal venous phase first, sir.
So in the arterial phase, anything more specific?
No, you have to look at other things which you look in arterial phase.
So it is an heterogeneously enhancing tumor is present. There are no replaced vessels visible on the arterial phase. The SMA seems to be uninvolved by the tumor, sir. So for the venous relations, I would after this go to the.
Also see whether GDA appears prominent. Are there any the celiac origin is fine. Okay.
Yes, sir.
What about the inferior pancreatic artery? Because you try to get the more information from your imaging.
Go a little slowly so you will be able to appreciate whatever Kalai has said.
Okay, sir.
Okay.
Because you don't want any saturation syndrome.
You can see all the vessels.
Yes, sir. So the celiac and the common hepatic artery seem to be okay in the section, sir. The GD appears to be involved in the tumor. I would further go to the portal venous phase.
Okay.
Good morning, Sastry sir.
Good morning. Sorry to join late. I couldn't help it. But I've been following it. Please go ahead.
Yes, sir. Sir, in the portal venous phase, there are collaborative no liver lesions as visible in the arterial phase also. There is a pancreatic head mass, which is heterogeneously enhancing. There is focal abutment to the SMV present, sir, with a contact less than 180 degrees, sir. The pinoportal and also abutment at the focal abutment at the splenoportal confluence.
Can
But
you
the
just
portal,
stop at the point where you're saying there is a abutment?
yes, sir. Yes, sir.
So what additional information would you want to tell us when you say abutment over here?
Yes, sir. There is a contour deformity of the vein present with a.
So what is joining at that level?
Sir, is the first. It's the inferior pancreatoduodenal vein is joining, sir.
No. Just go up. Just go one cut up. Now, what is joining now? Just trace it down. Yeah. Now come down.
Stop.
So what is that?
Sir, it's a coronary vein, sir, from the stomach. Sir.
What is it?
No. It's the first jejunal vein, sir.
No. That's a gastrocolic trunk.
Yeah.
Okay.
Going up, no, how can it be jejunal? The one which is traversing upwards.
Yes, sir.
So what is the significance of that? Yeah, just stop there. Yeah, no. Stop here. Yeah, just one more cut down. Yeah. Yes.
It is abutting the gastrocolic trunk, sir. So during the dissection surgery, we may have to sacrifice the right colic vein if it is also abutting at the confluence.
So normally you preserve that?
Colic vein, yes, yes, sir, preserve that. Right gastroepiploic, we usually tie it down, sir.
No. Unless you divide that colic vein which is joining into the gastrocolic trunk, you will not be able to complete your cauterization and exposure of the SME, right? Otherwise,
Yes.
colon cannot be completely nicely separated off from the.
And also,
Yes.
if you are doing robotic or laparoscopic, it is one of the most important vessels which you have to identify. In open, it is all right, you can. But in laparoscopy, it will be one of the most important vessels to delineate before. So it is better to visualize it on your CT plates before going ahead. Anything else?
The importance of knowing that is because so normally this is done as one of the initial steps.
Yes.
So when it is involved, so probably you don't do it in the beginning because you try to dissect in that area, then there is a very high chance of having bleeding in the initial phase itself. So you do it later. So that will help in your surgical planning.
Okay, sir.
That's why the most important to read the images. That will avoid a lot of intraoperative complications. Okay, so that is what.
Back to your portovenous junction, porto junction.
Yes, sir.
There is some abutment. What else you want to know over there?
So whether the inferior mesenteric vein it is joining the splenic vein separately, or it is draining into the confluence, sir? If we are planning,
Can you tell what is there in this case?
I'll try to see.
So what is that which is joining now?
Yeah, it is the IMV, sir, over here, sir. It is joining the splenic vein.
No, you show the splenic vein, sir.
Splenic vein is here, sir.
Splenoportal. First go to the splenoportal junction. Okay.
No,
Then come down.
Come down.
Yes.
Yeah.
Start coming down. So now you look at the other veins. So you splenoportal is free junction.
So it appears free on this scan. I would see for coronal emerges and discuss with the radiologist, sir. From what I can see, it appears free over here, sir.
So when there is a portal vein involved, I mean suspected portal vein involvement, you feel that there is a possibility of a resection. So what are the veins you try to see? The drainage of what veins you have to see on the image.
Sir, in case of suspected portal vein abutment, I would first see the length of abutment, the degree of contact with the portal or splenic SMV, whether it is any contour deformity or teardrop deformity present or not. I will see whether the IMV is draining into the confluence or it is draining in the splenic vein. I would see the first and second jejunal veins.
Okay. One is IMV, then
first jejunal trunk, sir.
Okay, then
the IPDV along with it.
Then the left gastric vein.
Okay,
so you should be clear about left gastric vein, splenic vein, where is IMV draining, where is first jejunal trunk. Okay, because if you have to resect, for example, splenic vein, at least of these three veins, left gastric, splenic, IMV, at least one should be preserved, drainage of one, to prevent issues with drainage. Okay, so you should be clear where all these veins draining.
Yes, sir.
You can see in this.
So IME is draining to the splenic vein, sir. That is clear. That would be preserved, sir. The first.
Which is IME?
Yes, sir. This one.
No. That is not IME. No, that is not IME. See, basically, it's very easy. You see a vascular structure, you trace it forward, backward. You see where it is coming. So that's how you find out what is IME. What you are showing is not IME. That is actually an arterial branch which you are seeing in the venous space.
Yes, sir.
Go down.
Now you see, what is that vein? Which you are.
It is draining here, sir.
Okay. So it is actually draining into the
splenic vein.
It's not draining into splenic vein. It's draining probably into the SMV one. Okay.
I think it's draining in the SMV rather than in the.
Okay, sir.
So you go up. Okay, then you mentioned about first jejunal vein. No, so where is that? First jejunal trunk. Okay, quickly, because
yeah, it is here.
No, come down. Yeah. No, that's splenic. This is IMV. Then come down. This is first jejunal. Okay. So anything different in this case? First jejunal trunk, the way it is joining.
So it is probably going anterior to the.
So it is. Is it common?
No, sir. Usually it is posterior to the artery, sir.
Okay.
In 20% of patients.
Again, it's important. Otherwise, you will be searching for that during the intraoperative.
Yes.
Okay. Then the left gastric vein. So you try to see that. Okay. So basically, you need to practice.
Okay, sir.
Reading the images.
This is the left gastric vein probably.
Draining into the. Again, you also need to be sure of aware of the arteries also, because you will be seeing some of the arterial branches in the portal phase also.
Yes, sir.
Fine. So okay. So you now can give your interpretation based on the imaging.
I would like to see the CT report, sir. From this, it is a pancreatic head uncinate process mass, sir, which is focal abutment to the superior mesenteric vein present. And there is bilateral IHBRD and dilated pancreatic duct up to the level of the tumor, sir. There is no associated gastric outlet obstruction. There is no regional lymphadenopathy. There are no signs of free fluid or any liver lesions, suspicion of any metastatic disease.
So based on this, what will you label this tumor as? A straightforward tumor, a BRPC or advanced?
So no, I would not label it as a borderline resectable, sir, because there is no arterial involvement. The venous involvement seems to be resectable or reconstructible vein, sir.
What is ABC of BRPC?
Sir, BRPC, it has 3 categories according to the MD Anderson grading, sir. BRPCA is anatomical grading, in which we see the involvement of the venous SMV and SMA. In BRPCB, it is a biological, in which we see there are signs of any regional lymphadenopathy suggestive of any advanced disease, or whether it is elevated CA19-9 levels biological marker. And BRPCC is a conditional variable in which the patient's general condition, ECOG status, performance status is seen whether the patient is a surgically candidate or not, sir.
So based on this, did you see the relation to the duodenum and the tumor for resectability, or is it not important?
It is important, sir. In the BRPC, we see the level of the venous involvement, sir. We see the SMV involvement compared with the level of the duodenum. As they have graded as 4.
This patient has.
So it has group A patient, sir. Means the extension is up to the superior margin of the duodenum. Group B is up to the middle of the duodenum. Group C is inferior margin of duodenum, and D is beyond that, sir. The patient falls in group A.
B or A?
Yes, sir. B or A, sir.
I think the statement which you made, this is patient having a resectable, reconstructible portal vein. That's why I won't call it as borderline, but as resectable. That's not a right statement. So if you don't have a reconstructible portal vein involvement, so what do you call that tumor? You call that as borderline resectable?
Sir, without any reconstruction is a locally advanced. A reconstructible vein is a borderline.
So that is different, no? So locally advanced or unresectable. So borderline resectable means it is actually resectable, but the direct surgery might increase the possibility of a R1 resection or maybe a poor outcome in the long term. Okay. So they are potentially resectable, but you don't go ahead with the resection because of the possible negative factors after surgery, direct surgery. So that's why they call it borderline resectable. Okay.
Agreed.
So you should be clear with that. But here again, you will not tell this as borderline resectable because the angle of contact is less than 180. So it's not portal vein involvement.
Yes.
Okay. So there is a possibility that there may not be any venous involvement.
Yes, sir. Agreed.
Okay, just one step behind. Before you decide on the resectability, have we confirmed the malignancy here? Is it still possible that it is the chronic pancreatitis with a head mass?
Sir, for that, sir, the patient firstly has no history of recurrent episodes of pain in the past. Second, the parenchyma appears normal. There is no signs of atrophy of the pancreatic parenchyma. There are no calcifications present. And there is no history suggestive of any exocrine or endocrine insufficiency that we suspect a chronic pancreatitis picture in this patient, sir, based on the history and the radiological imaging findings.
all these findings you said of how much of predictive value? Meaning, are they mandatory for a diagnosis of chronic pancreatitis? He did have pain. You did give some importance to pain, as I was listening to in the clinical profile.
Yes, sir.
He had some vomitings, which are not you gave a lot of importance to the vomitings also. And then now you have a head mass with a duct cutoff and pancreatic ductal dilatation and obstructive jaundice with a lower end obstruction. How certain are you about the malignancy? Do you think there is no need for confirming the malignancy here before, as you assess the resectability?
Sir, there may be a remote possibility, sir, but even the yield of a biopsy in case of pancreatic tumors is not 100%, sir. We may still have a negative biopsy, and since the patient is symptomatic, it is obstructing the biliary tree, which is hampering, which is raising the bilirubin levels. She has cholangitis and acolic stools. So even if the biopsy,
Did she have cholangitis?
subclinical cholangitis, so there is raised OTPT levels and ALP, and she has having acolic stools with pruritus, which is disturbing her routine life. So even if the biopsy is negative, we may still proceed for the surgery, sir.
Would you do upfront surgery without biopsy in this patient?
Yes, I would, because sir, there are no signs of chronic pancreatitis from this, sir. So in this case, sir, I would, sir. But if there are any symptoms or signs of chronic pancreatitis with a head mass, I would proceed with the biopsy, sir.
As you were discussing, if it is a borderline operable head mass due to malignancy, would you completely leave out biopsy?
No, sir. No. If it is borderline, sir, this is the does not is not falling into the borderline resectable, sir. If it is borderline resectable, I would proceed with a biopsy because the patient would require neoadjuvant treatment or before planning of the surgery. Then I would go for the biopsy, sir.
The biopsy comes negative, then will you not give neoadjuvant in a borderline?
Sir, I would retake the biopsy, sir. The medical oncologist, without confirmed proof of malignancy, don't start chemotherapy, sir.
If that also comes negative, then 2 biopsies are negative, but you want to give neoadjuvant because there is some distortion of the portal vein, which you, as you said, so.
Sir, I would see if she falls into borderline resectable, whether it is reconstructible or not. And after discussing the prognosis and risk of the surgery with the patient, I would proceed for surgery, because without a biopsy, sir, we cannot give chemotherapy, sir.
Okay. What are 2023 ESMO guidelines saying regarding biopsy in the borderline resectable?
Sir, I'm not sure about it, sir.
ESMO guidelines, if the 2 biopsies are negative, but there is a highly clinical and radiological suspicion, here the CA99 is normal, but if the CA99 is elevated, those patients can be started without a biopsy. So that is 2023 ESMO guidelines, but routinely our oncologists also will insist on having a biopsy report before starting them. So these are the guidelines.
Okay, sir.
Okay. So you just have to keep that in mind that you can, but what you said is right. That is what is followed widely. Okay. But then there are some circumstances. So as quoted by Dr. Prabhu, so there is some, you have guidelines to suggest that you might start in a selected cases. But again, after clear explanation to the patient, okay, you have to properly explain, document it well, and then you can possibly.
Yes.
Would you consider neoadjuvant treatment in an operable head malignancy under any circumstance?
So in this case, are you going to now start?
So no, first I would like to view the CT report, sir. I missed it. Sorry. And since the patient is having subclinical cholangitis and pruritus, I have started the patient on medical therapy, sir. I would.
So the question is very clear. In an operable CA head pancreas, would you give neoadjuvant?
So it is not the standard of care currently, sir. But there are some centers who have claimed that increases the RZO resection rate. It helps in the biological selection of the patient, and but it has not been transformed to increase overall survival in the reports which they have produced, sir. So some centers do give neoadjuvant therapy in resectable pancreatic head cancers also, but it is not the standard of care currently, sir.
No, when the question is asked, you should be more specific with respect to the evidence. So what is the available evidence? So which means you need to quote the trials. Okay, not many trials are there, but so there are some specific trials which you should put and then give your answer. It's not some centers.
Yes, sir.
So what is the available evidence with respect to this specific question?
Sir, I don't know the exact trial names, but I know the criteria that they have given in resectable tumors, and it has with the aim of increasing the other resectability and for biological selection of the patient.
Fine. So basically, you need to read. So there are now 3 trials available. Okay, specifically in the resectable pancreatic cancer, obviously with the contrasting results. So then when you quote and give the answer, then it will be more specific.
Okay, sir.
We just saw the CT report.
Yes, sir.
Can you get the CT report? What next?
From the CT report, so it's a resectable pancreatic head mass without any gastric or obstruction, causing bilobar IHBRD and pancreatic ductal cutoff, sir, and a focal abutment to the SMP. The planes are preserved. There is no significant lymphadenopathy or signs of any metastatic disease present, sir. So in this patient, sir, the patient had raised liver enzymes, sir. So I have started, as I told, I have started antibiotic therapy. I would see how the patient is responding to the antibiotic therapy with follow-up with liver enzymes, sir. If they are decreasing trend, I would like to proceed with the surgery, sir.
Okay. If it is not, so what is your criteria? You repeat the LFT, right?
Yes, sir.
And if the enzymes are elevated still?
Sir, I would consider escalating the antibiotic. If the enzymes are not reducing or they are rising trend or persistently they are raised, I would consider endoscopy and preoperative stenting in the patient, sir, before proceeding further, sir.
Okay. So now you want to proceed with surgery, right?
Yes, sir.
So what will be the specific modifications you will do in your steps? You will do like you proceed in a usual way in this case, or will there be any modification in your steps?
I would proceed with a staging laparoscopy first, sir, to confirm any gross metastatic disease or liver lesions or peritoneal deposits present or not. Then since it is a focal venous abutment, there is no arterial abutment. There are approaches present which help us go towards the vasculature first, then mobilize.
What the question is, there are multiple procedures, but what will you be doing in this patient?
Now you have seen the image. Okay, you can tell broadly. I mean, how you are going to approach.
You said diagnostic laparoscopy. Is it across the board or particularly for this patient? Is it a routine for all CA of pancreas?
We in our center usually do for all CA pancreas, but NCCN recommends if there is a raised CA99 levels above 100 dash units per ml, then a staging laparoscopy is indicated. But we usually do it for all patients before proceeding.
No, it's not only CA99, about the location of the tumors. Okay, location, obviously, yeah, the question was specific in this case, CA head. Okay, when this body, you do it in all case. CA head also size criteria?
So usually if it is more than 4 centimeters, then there are chances of metastasis present being more, sir. Then staging laparoscopy is indicated.
Staging laparoscopy is advocated in a tumor which is large, or the patient has received a neoadjuvant, or patient has BRCC. These are the patients where you expect them to have, or CA19 which is elevated. So these are specifically in the text indications for doing a diagnostic lab. A routine diagnostic lab is not advocated in all patients of operable CA head pancreas. Agree, Dr. Sastry, Dr. Kalay?
Yeah, that's exactly what I was. But then institutional protocols could be different. There's nothing against doing a staging laparoscopy, but it's not mandatory. It's not followed by everybody. To limit various your operative timings and many.
You want to do a PET scan in this patient?
Sorry, sir.
PET scan?
Sir, it is not. I would not like to do it in this patient, sir, because in case of adenocarcinoma pancreas, the PET has low yield of any additional information as compared to a CECT, sir. So some studies have shown it has changed the management up to 30% of patients, but
1 in 3. So still you don't want to do it?
Sorry, sir.
30% is 1 in 3 patients. It will change your therapeutic management. Still, you would not like to include PET scan in your protocol?
Sir, in this patient, the CA19 levels are not raised, sir. The mass size is less than 4 centimeter. There is no significant lymphadenopathy. There is no doubtful lesion present in the liver. With all these factors, I would feel that a PET would increase the cost and radiation exposure without giving any significant benefit to this patient, sir.
What about endo-ultrasound?
Endo ultrasound, sir, it has shown to be complementary to CT, specifically in case of venous involvement, to see the degree of venous involvement. But again, in this case, the CT is providing us with a good enough picture and details, and we are not planning for a biopsy in this patient. So I would not do an endo ultrasound in this patient.
Okay, going back to your management, surgical management.
After doing the staging laparoscopy, I would proceed with a plan for an open Whipple's procedure, sir. Firstly, I would, after opening the abdomen, I would see for the mass's mobility and to see if it is mobile or not, any extent if it is grossly palpable, it is going towards the artery or not. After that, I would proceed with the cattle brush maneuver and pauperization of the duodenum first.
So you
And
will do a routine way in this patient or anything specific. It is like any other CA pancreas you want to proceed. Depending on the location, doesn't change or it's the same for everywhere.
We can go for an artery first approach, sir, depending.
What will be your indication for artery first? Will this be an indication for going for artery first?
Sir, I would proceed in a standard fashion, sir, because the arterial involvement is not there, sir, and in this case, sir.
You said after opening you test for mobility. How do you test for mobility without mobilizing it? You would test, and what kind of mobility are you expecting to see?
It's a gross test, sir. We just try to see whether it is free from retroperitoneum or not.
I think no need to mention it. Basically, no, don't use the terms which are non-specific, which are not going to be of any use. Okay. See, basically, most of the things are based on the imaging. Okay. And then you confirm those, what you are expecting based on your image, you just confirm those findings intraoperatively. Now, in this case, there is a suspected venous involvement. So it's always preferable to go with the artery first approach in this case. Because we have discussed, no, there was a gastrocolic trunk involvement. So that area, to dissect it without mobilizing out from the artery will be difficult in this case. Okay, so you have to plan for the artery first approach in this case. Whenever there's a suspect venous involvement, that should be the approach. So you are aware how to approach the artery first?
Yes, sir. In different literatures, there are 6 approaches described to go for the artery first, depending on the tumor location.
So in this case, which approach you will plan?
Sir, a right approach or a posterior uncinate approach would be better.
So also you have to remember that it is not always one approach. Okay. Often you will be combining. You'll be combining. So often you will be combining two approaches. That is the right and the posterior. Most often it is combined. So I think we are 9 o'clock, so maybe we can ask comments from others, or you want to have some more questions?
Desai, I think you're done well, but the problem is some of the statements are very dogmatic, which the examiner might not take it. Like, for example, when Kalay asked you about suspecting periampullary, you said straight away went for CT. Side-viewing endoscopy, you said is not going to make any decision. I think these statements should be very cautious in telling. So that will give a bad impression to there can be difference of opinions, but cannot be dogmatic in the exams. Endoscopy definitely forms a first line of investigation when you find a suspected periampullary mass, and biopsy definitely will help you in counseling your patient for resection.
Okay, sir.
So, and the yield of side-viewing endoscopy of a periampullary is much higher. Okay, so the other thing is about the role of US. Definitely there is a role for US in this patient, and even probably you can even do an FNAC, because the yield of FNAC even in head masses is to the tune of around 80%. The advantage of doing and US is nowadays is not associated with so many complications which has been mentioned in the past reports, like local recurrences, all that's been excluded now. So you can do a US FNAC. There are many people who will advocate US FNAC, so there's nothing against it. So you might also argue saying that I'm going to anyway operate it even if it is negative, is also as taken. But only you will be, if you have a positive US FNAC, you can counsel your patient well. That's an established case of a CA pancreas, right?
Okay,
so
yes.
So that is the advantage. Otherwise, you have a patient is going to ask you, how do you say it is cancer? So this is the problems when counseling your patient. So don't be negative or don't be against it. Okay, so you should be diplomatic in answering these questions in the exams. Right?
Yes, sir.
Otherwise, overall, you have done well.
Thank you.
We have other faculty here, Dr. Sadiq, Dr. Avinash.
No, I agree with Pradeep actually. I have no other comments. That's okay.
Thank you, sir.
I just wanted to make one comment, which I was not there earlier for the clinical profiling. See, although it's not that important these days for the history and how much of importance you give to the history, but the weightage you give to the symptoms is important. Say between pain and weight loss, I would give more importance to weight loss than the pain, which is not a classical pain here anyway, either for a stone disease or for a malignancy, and pain occurs in both. Whereas weight loss, a significant weight loss, I think weightage should have been given to that, and your first possibility should have been malignancy rather than a stone disease. Well, these things do not matter much in practice, but then the way you think and systematic training of your thinking process, this is important.
Okay, sir.
Sadiq.
Not audible, sir. Not audible. Not audible. Okay. I think, yeah, fine. Sir, I think it's not going to make a comment.
Okay. So can we wind up Professor Sastry, Kalay and Ramakrishna, Prabhu?
I think he has done fairly well. Definitely was a fine tuning is always wanted in. So there is no perfection here, but I think you've done fairly well.
Yeah, I also agree. Did well. You can just improve the way you read the images, but overall, you're done well with respect to the approach is fine.
I think so. We have done quite well. polish a little bit about the way you are going to talk rather than make a dogmatic about your opinions. So I think it's quite good presentation. Thank you.
Thank you, sir. Thank you.
Can you wind up, sir?
Yeah.
Thank you, Sastry, Kalay and Prabhu, and thank you, Desai.